Hello people, this is Dr. Muskan this side, and today I am going to discuss one case. Here is 53-year-old male who has came to ER with chief complaints of fever since 6 days, pain in abdomen since 1 day, constipation and obstipation since 1 day. He was already diagnosed with dengue and was given 8 fluids in 3 days. On arrival in the ER, ABCS was done. Airway was patent, that means there were no signs of airway obstruction. To your acknowledgement, what are the signs of airway obstruction? They are dyspnea, dysphagia, stridor, hoarseness, unable to breathe properly while sitting and lying position. On breathing assessment, respiratory rate was 46 per minute, that means there was tachypnea. SpO2 was 45% on room air, that means there was desaturation. So there were signs of respiratory distress present. On circulation assessment, pulse rate was 97 per minute and was normal because normal range lies between 60 to 100 per minute. BP was 70 by 40 mmHg. My dear friends, this is hypotension. Sensorium was alert. GCS was 15 by 15, that is E4, V5, M6, that means eyes were open spontaneously. Verbal response was oriented and motor response was also obeyed when the command was given. RBS was 90 mg per dl. HOPI, patient was apparently asymptomatic 6 days back. When he was diagnosed with dengue fever, he came to Sharda hospital. There were complaints of pain in abdomen, which was sudden on onset, non-radiating, associated with constipation and obstipation. He also has history of low-grade fever, 98.6 degree Fahrenheit, intermittent in character, associated with chills. There was negative history of that there was no bleeding manifestation. We ruled out dengue hemorrhagic fever because in dengue hemorrhagic fever there is a triad that patient should have fever, thrombocytopenia, and your bleeding manifestations such as epistaxis, your ENT bleed, your oral bleed, or your hematomasses, hemoptysis, your melena, hematochezia, or any other bleeding manifestation in the body. So there were no bleeding manifestation. Past history, there was no history of type 2 diabetes mellitus, hypertension, thyroid, epilepsy, TB contact, or any other chronic illness. Past personal history, the patient is occasional smoker and occasional drinker. On examination, decubitus was patient was uncomfortably lying on the bed because of NIV mass. He was agitated but oriented to time, place, and person. Vitals of the patient were normal except respiratory rate, which was 34 per minute. That means there was tachypnea, and parallel was present moderate. Cyanosis clubbing absent. Edema was pitting. Edema which was present in lymphadenopathy was absent and icterus was present. On systemic examination, CNS examination, GCS was 15 by 15, bilateral pupil reactive. CVS is S1, S2 positive. Abdomen was tender, distended. Respiratory examination, bilateral Krebs was present. Now, investigation picture of the patient. ABG shows respiratory alkalosis, and lactic acid was also increased, which shows us the interpretation that there is cellular injury, hypoperfusion, or ischemia. Further, patient was also having ARDS. We have calculated PaO2 by FiO2 ratio, and how we calculated PaO2 you will get from ABG, FiO2 will get from ventilator screen, and when you will divide it, so it will be 14. In this patient it is 144.8, that is it is less than 200, that means this is critical respiratory health. क्या होता है क्राइटेरिया FiO2 और PaO2 FiO2 रेशो का? अगर 400 से ज़्यादा है दैट मीन्स इट इज़ नॉर्मल, अगर 400 से कम है दैट मीन्स हाइपोक्सिया है, अगर 300 से कम है दैट मीन्स रेस्पिरेटरी फेलियर है, अगर 250 से कम है दैट इज सिवियर रेस्पिरेटरी फेलियर है, और अगर 200 से कम है दैट मीन्स क्रिटिकल रेस्पिरेटरी फेलियर है. नाउ रेडियोलॉजिकल एग्जामिनेशन पे देयर वाज हेट्रोजेनस ओपेसिटी विच वाज प्रेजेंट, दैट वाज शोइंग द डायग्नोसिस ऑफ ARDS, एंड कार्डियोमेगाली वाज देयर वाज बायलेटरल प्यूरल effusion लेफ्ट साइड पे ज़्यादा था एज कम्पेयर टू राइट साइड. USG picture findings थी, there was bilateral pleural effusion, mild ascites. IVC was less than 50% collapsible with respiration, and pericardial effusion was there. CBC picture shows anemia and leukocytosis. LFT picture shows hyperbilirubinemia, serum transaminitis, hypoalbuminemia, and increased alkaline phosphatase level. KFT picture shows hyponatremia. Dengue test, malaria test, typhoid test, everything was negative. HIV 1-2 rapid test, HCV, HBS antigen test was negative. Now I was checking out sepsis ki hai ki nahi. I just check SIRS, that is systemic inflammatory response syndrome. That was 2 by 5. There are 5 things in which we have to see. There was tachypnea and hypertension out of 5. sepsis was present. How we see sepsis है कि नहीं है? 2 positive criteria for SIRS and infection should be there. So TLC was raised and 2 criteria of SIR was present, that was tachypnea and hypertension. Severe sepsis was not there because lactic acid का level 2.6 millimole per liter था, and severe sepsis होने के लिए you should be having lactate का level more than 4 at least millimole per liter. Now then I ruled out dengue shock syndrome in this patient. How I ruled out? There are 7 most peculiar features of dengue shock syndrome. One is tachypnea. Okay, it was present in our patient. Cool extremities? No, it was not present. Extremities warm थी. Delayed capillary refill time? It was good capillary refill time. Weak pulse? No. Pulse pressure less than 20 mmHg? No, this was also not followed. How we see the pulse pressure? Systolic blood pressure को diastolic blood pressure से माइनस करो. मेरे पेशेंट में 41 था, and dengue shock syndrome में should be less than 20, so it was also not present. Hypotension 90/60 से कम होता है, मेरे पेशेंट में 99/58 था. Reduced blood brain perfusion, उसके लिए हम मैप देखते हैं. मैप जो था वो 65 से ज़्यादा होना चाहिए अगर रिड्यूस बताना है. मेरे पेशेंट में 77 था. तो आउट ऑफ 7 2 वॉज पॉजिटिव, सो आई रूल्ड आउट डेंगू शॉक सिंड्रोम. देन आई सॉ कि शॉक है कि नहीं है. उसके लिए मैंने शॉक इंडेक्स निकाला था. वी कैलकुलेटेड बाय डिवाइडिंग हार्ट रेट बाय SBP. सो 94/114 इट कम्स आउट टू बी 0.8. दैट मीन्स माइल्ड शॉक वॉज प्रेजेंट. आप सर्च करना नेट पे, देयर इज शॉक क्राइटेरिया माइल्ड मॉडरेट सिवियर. इफ़ शॉक इंडेक्स कम टू बी 0.6 से 1 के बीच में, 0.1 के बीच में, सॉरी 0.6 से 1 के बीच में, इट इज़ माइल्ड शॉक. अगर 1 से 1.4 तक आते हैं तो इट इज़ मॉडरेट शॉक. अगर 1.4 से ज़्यादा आता है दैन इट इज़ सिवियर शॉक. नाउ वन क्वेश्चन वॉज देयर विच वॉज वेरी ब्यूटिफुल क्वेश्चन. इट वॉज कि ABG में रेस्पिरेटरी एल्कलोसिस हमने बोल दिया, बट लैक्टिक एसिड का लेवल 3.3 मिलीमोल पर लीटर है, तो हम उसको हैगमा क्यों नहीं बोल सकते हैं? अगर लैक्टिक एसिड का लेवल जनरली बड़ा होता है, व्हाट वी से इट इज़ अ कॉज कि हैगमा है. But we never use, the answer to the question is we never use lactate to make a diagnosis. We use lactate to support our diagnosis. So हैगमा है तो it is supporting. अगर वो मतलब हमारे पास मेटाबॉलिक एसिड होता है तो हम उसको सपोर्ट करने के लिए यूज़ करते हैं, बट हम उससे डायग्नोसिस नहीं बना सकते कि भाई हाँ मेटाबॉलिक एसिडोसिस ही है. वो रेस्पिरेटरी एल्कलोसिस है हमारे पास. सो दूसरा हैगमा हमें किस लिए मदद करता है, मतलब लैक्टिक एसिड का लेवल सेप्सिस बताने के लिए कि कितनी सिकनेस है पेशेंट में. Now further, what was the management which was given to the patient? Patient was of ARDS, so treatment was given according to the moderate to severe ARDS thing. Conventional intubation, early low tidal volume, early prone position. We initiated mechanical ventilation because there was disproportionate high minute ventilation and shock, which was also affecting the right ventricle. So that was also going in dysfunction because it was ARDS induced. Further sedatives and paralysis was done depending upon the parasympathetic drive. So patient जो है वो NIV assisted ventilation पे था. We avoided giving sedatives या फिर relaxants. क्यों? क्योंकि ये medications further patient के vitals को affect कर सकती थी. So what we have actually executed, there was urgent resuscitation with fluids. Antibiotics was operated, gentle NIV resuscitation was there, trial to allow resuscitation was there, urgent invasive lines to support the patient resuscitation care. Now when I saw the same patient in the evening, here it is done, management कर दिया, आपको हिस्ट्री बता दी, इन्वेस्टिगेशन बता दी, मैनेजमेंट बता दिया. सो इन द इवनिंग जब ABG रिपीट हुआ, लैक्टेट का लेवल रिड्यूस हो गया 1.9 तक. यूरिन आउटपुट ब्रिस्क हो गया था. नॉरएड को भी टेपर कर लिया था 2.5 ml per hour. देयर वाज नो सिग्निफिकेंट टेकिकार्डिया. शॉक इंडेक्स सेम था, माइल्ड शॉक इंडेक्स वाज देयर. PaO2 FiO2 को रेशियो वाज 154. दैट वाज द शेड बाइट. पहले थी 144.6, अब 154 है. रेस्पिरेटरी वाज 35 to 40. सो व्हाट मैनेजमेंट वी हैव गिवन इन द इवनिंग, पेशेंट की कंडीशन बेटर हो गई. That was NIV care, fluids and steroids. So if there was a thing, if any transition occur in the lactate level, vasopressors or it take a U-turn or get worse, so instead of having fluids or NIV, we thought कि we will make the patient intubate or initiate PPV. So next morning when I saw the same patient, lactate level was reduced to 2. पहले it was 2.6, it reduced to 1.9, and now it reduced to 2. So Respiratory rate was also reduced to 25 to 30 per minute from baseline 35 to 40. Now, you know why the patient condition has actually improved? Because we identified that there was secondary sepsis and we did the constant supervision. And there is one basic thing that in the sepsis patient, if we delay the treatment from 1 hour timings, then mortality rate will increase by 7.6. So patient condition was improved. Now on the day 3, progression was ABG was respiratory alkalosis, showing investigation picture was showing anemia, leukocytosis, increased urea, hypokalemia, hyperbilirubinemia, serum transaminitis and hypoalbuminemia. Septic shock was resolved today. Patient was on NIV alternated with HFNC. Now the treatment was given, that was syrup Potlor 15 ml TDS with half cup of fruit juice, but because Potlor was not available in the pharmacy, so they have given coconut water for the fluid management. And to your acknowledgement, I want to tell that potassium level get increased when we give the coconut water. Now on day 4, ABG showed metabolic alkalosis and vitals was normal. Urine output was also very good. It was input was 3520 ml per 24 hour and output was 3490 per 24 hour, and rest all seems to be fine and patient is good now. So it was really nice when I was updating on following up the case, getting to know how management was given, how patient was getting better day by day. I really enjoyed working on this case. I hope you have also enjoyed listening to the history of the patient. And at last, what was the final diagnosis of the patient? That was ARDS with secondary sepsis. So that's all. Dr. Muskan Bansal is signing off now.